Today we're talking vessels. No, not that kind. Oh, come on, I wish. Let's focus. Before we get into the nitty-gritty of blood vessels, we need to understand the process of dermoscopic diagnosis. Let's rewind back to 1761, when an ordained minister named Thomas Bayes was busy thinking up a theorem that would change the way we diagnose skin lesions, and a whole lot more. His theory boils down to this crucial question. Given what I already know, and with new evidence to hand, how do I update my beliefs? Let's see how this applies when a patient walks in to see you with a new skin lesion. You ask yourself, what are the chances this could be a melanoma, that most notorious and dangerous villain of skin lesions? If we grab someone randomly off the street, the odds are pretty low. But we know melanoma risk increases with age. And armed with that, we update our probabilities. Plus, add in the lesion location, maybe a family history, and the patient's skin colour. We update our beliefs. Now we look at how the skin lesion presents, hello A, B, C, D, E, and how it feels. And finally, we whip out that dermoscope. And at this point, we have a pretty good idea of the possibilities. But now we're asking, are the signs on dermoscopy lining up with our expectations? Here's where blood vessels come in. They're the last piece of the puzzle, not the first. Why? Because they're often the least reliable feature, unless they're a game changer. Let me show you. This lady walked in with a lesion that looked like a classic seborrheic keratosis. She's the right age, it's in the right location on her trunk, it was nicely well demarcated, with even a bit of scale. All perfectly textbook stuff. Dermoscopy is initially reassuring, but then I see something weird. Serpentine vessels? What? I've never seen those in a seborrheic keratosis before, and suddenly my brain goes ping! My beliefs are updated. Could it be a basal cell cancer? Or dare I even whisper it, a melanoma? I had to excise it. And bingo! It was a BCC, all because of those vessels. So here's my first rule. Blood vessels don't matter until they do. Skin blood vessels reside in the papillary dermis. When these papillae elongate or tumours trigger new vessel formation, or there's skin inflammation, the vessels change. You can only see these vessels when the stratum corneum or top layer of the epidermis is thin enough, such as on the face, or when they're close enough to see the vessels. So when do blood vessels become crucial? The key lies in two questions. What shape are they? And do they follow a pattern? Let's dive into each. Shapes. We named vessels after the shapes they form within the skin. Hairpin or loop vessels. These form when the dermal papillae elongate, causing the vessels inside to twist around into loops. Common in our scaly 6 keratinizing skin lesions, most often a wart or seborrheic keratosis. Viewed end on, they're dots, but turn them sideways and parallel to the surface of the skin, they form a loop. The key question to ask is, do they have a halo around them? If yes, it's probably good and benign, like a seborrheic keratosis. No halo, watch out. Could be a BCC or a melanoma. Curved vessels, also known as comma vessels. I prefer calling them curved now because often they're more than just a comma shape. These shapes are typically seen in intradermal nevi. These are very common and don't always have visible vessels within them. Some are pink. You'll notice these vessels are very often out of focus. Glomerular, or if that's too difficult to say, commoner or knotted vessels is fine. These are tangled balls of red wool, often seen in psoriasis, stasis eczema, Bowen's disease, and even squamous cell cancers. They're larger than dot vessels and are formed at the end of dermal papillae. Dotted vessels are very common. You'll find these very often in inflammatory conditions like eczema, psoriasis, and things like Bowen's disease. But here's the twist. Dotted vessels also pop up in nevi and melanomas. Keep an eye on these, they can sometimes indicate superficial melanomas. Globular vessels, typically found in capillary hemangiomas, but other forms of angiomas as well. We call them lacunes because they look like little lakes of blood, so picturesque. Serpentine vessels, these are like snakes, twisting and turning, and just like a snake, they can bite. Keep your eyes peeled for these, as they are often linked to skin cancers and growing tumours. Straight vessels, you'll find these almost anywhere, but they're very commonly seen in sebaceous gland hyperplasia. Let's now turn to the different patterns you may see. Arborizing vessels. Warning! Once you start using a dermoscope, you'll see arborizing vessels everywhere. But there's a difference between these and branched and other types of vessels. Arborizing vessels are often seen in basal cell cancers as it grows, but they can show up in other skin lesions like keloids and skin cysts. This gentleman with a lesion on his cheek, which didn't seem to be anything, but on looking, he has got these arborizing vessels, which you can see are arising from the deeper normal dermal vessels. And again, this was a BCC on removal. Sometimes the arborizing vessels are very obvious, and when the BCC outgrows its blood supply, this is when you get the erosions and ulcerations. Clustered vessels. These are most classically found in Bowen's disease and appear as clusters of coiled vessels on a light pink background, sometimes with scale. Chained dots. These dots appear in a clear cell acanthoma, a rare benign skin tumour. It's called a string of pearls sign and is pathognomonic for these. So if you see it, you've got your diagnosis. Radial vessel types, typically seen in spacious gland hyperplasia, but can occur in other benign skin tumours as well. Reticular pattern vessels, common in sun-damaged skin or in something like rosacea. When you're using your dermoscope, take a moment to really observe the blood vessels in any skin lesion you examine. Learn to name their shapes, recognise any patterns, and note their associations. And over time, this practice will make it much easier to spot that odd one out. So stay sharp, ask the right questions, and use every new piece of evidence to update your diagnostic belief. The next time you see those vessels, remember, they could be the clue that changes everything. Now, you're going to be wanting to watch another video, such as this one here. Training a primary care dermoscopist for every general practice.